Recently published guidelines for the management of patients with acute deep vein thrombosis revitalized the interest for studying and understanding mechanisms behind the pain in venous disease, which is important for interpretation of clinical data, especially coming from the randomized trials. Unfortunately, the results of controlled randomized trials are frequently misinterpreted, leading to erroneous conclusions and wrong recommendations. This statement from the recent ACCP guidelines is a good example. The recommendation for not using compression is based on conclusion of a single randomized trial. The commentary suggesting use of compression conflicts with the conclusion of the same randomized trial. The key missing point in this interpretation is the study's intervention was initiated not earlier than 2 weeks after the first clinical encounter of the patient with acute DVT. Let's take a look why the timing of intervention is important. There are 4 main mechanisms of pain acting during the transition from acute deep vein thrombosis to post-thrombotic disease. Inflammation is perhaps the most important in the context of this talk. Multiple studies have looked at the circulating inflammatory biomarkers at the time of acute vein thrombosis. However, the most recent meta-analysis of those studies show that neither one of those biomarkers can predict development of post-thrombotic disease. Closer look at the data reveals an obvious reason for this failure. Different processes occur at different times. Some of them happen inside the vein, and some act outside the vein, leading to 3 different pathological changes or their combinations. This longitudinal study from Netherlands provides an intriguing insight into the timing of the events. The acute biomarkers that are associated with objective signs, such as edema, were associated with a venous obstruction. However, reflux, although was connected to the post-thrombotic disease, was independent from acute inflammatory response and related mainly to pain, not swelling. In summary, different mechanisms dominate in pain genesis during 3 different stages of the disease. In the acute phase, inflammation directly causes pain by excitation on neuroreceptors. In addition, increased filtration raises compartment pressure, also causing pain. During the subacute phase, inflammation continues to act on the nervous system. Variation in the magnitude and effectiveness of inflammatory response inside and outside the vein lead to outflow obstruction and increased pressure in deep veins, which becomes the dominant mechanism of pain. Finally, in the chronic phase, reflux initiates and maintains the later inflammatory response. It also may lead to the lack of ambulatory pressure drop in superficial veins, making both mechanisms of both hemodynamical phenomena dominant mechanism of pain in this phase. Recent neuroscience findings unveil another important mechanism of pain. In addition to the irritation of peripheral receptors, acute pain activates a number of biological pathways. If it is not interrupted, acute pain causes structural changes in the neural system, which maintains the chronic pain even after the initial inflammation is completely resolved. This is one of the reasons that this and other randomized trials fail to show clinical benefits. In summary, the key mechanisms of venous pain are inflammation, obstruction, and reflux. But different mechanisms dominate at different times and act differently in deep and superficial systems. If acute pain is not timely resolved, structural neurological changes may occur, leading to chronic pain.